And good morning, good morning, good morning. Dr. Chris Roddenberry coming to you from the Chautauqua Institution in Western New York. How's everybody doing today? Sorry, what in the world was that? Hold on. I'm trying to... Dadgummit. I'm trying... Let's see... July 18th. This is us right here. Okay, there we go. There we go. Okay, fantastic. Got everything set up. How's everybody doing today? Good to see you, Dimitro. Good to see you, Johanna, if you were on the broadcast this morning, or whoever it is, that other person. Thanks for coming today. Hope you're doing well. It's a rainy day up here in New York. I hope it's a nice day down there in Raleigh, North Carolina. So this week we are talking about chapters 14 and 15. I want to congratulate everybody. We are now in the final week of this class. Yay, I know you're totally excited, but we are here. We have finally finished this class. And don't forget, if you keep doing this a couple more semesters, you will be very close to whatever academic degree it is you are interested in. So I want to congratulate you, but I want to tell you to keep on going as we finish up this week 8. All right? Fantastic. Hey, good morning, Matt. How you doing? I sent you a text. I got your message earlier this morning, and I took care of the thing you asked me about. So I hope that's okay. If you have any more questions, Matt, go ahead and just send me a text at your convenience so we can talk about anything you need to talk about. Okay? Fantastic. So let's see. Let's go to this. Today we're talking about chapter 14, psychological disorders. We'll be talking about that for the next couple of days, and then we're going to be moving on to chapter 15 to talk about treatment of these psychological disorders. So let's go ahead and talk about this. All right, here's the deal. If you have question, Matt or Dimitro. If you fell off your bike today and hurt your arm really, really bad, and you thought you might have broken it, you would go to the doctor. What would you expect the doctor to do to diagnose whether or not your arm was broken? What would you do? What would you do? Hi, good morning, Johanna. So, if you're going to, if you thought you had broken your arm and you went to the doctor, what test would you expect that doctor to do to tell you if you had a broken arm or not? Question. Who can answer that question? There you go. Take the X-ray. How would you feel if your doctor diagnosed you with a broken arm, but didn't without doing an X-ray, Matt? What if I just felt it and said, oh yeah, this feels swollen and it hurts and you can't lift it up? It's probably broken. Let's go ahead and wrap that sucker up. How would you feel if your doctor diagnosed you without an X-ray? You probably wouldn't like that at all now, would you? Now, here's the weird thing. When we go diagnose psychological disorders, there are no biological correlates, no tests, no ways in which we can confirm the biological existence of a psychological disorder. There is no blood test for depression. There is no X-ray for schizophrenia. You'd be a little concerned, wouldn't you? There are no biological tests for any psychological disorder. Instead, psychological disorders manifest themselves in the way we behave, we think, or we feel, right? And so there is no biological indicator. So I have to go in there and try to figure out whether or not you have a psychological disorder. Now, this may seem weird, it may seem non-scientific, but this is the way we have to do it. In order to decide whether or not people have psychological disorders, we look for 3 characteristic qualities of their behavior. Is their behavior maladaptive? Is it causing them from taking care of their fundamental requirements? Are you too anxious to leave your house and go to your job and you keep getting fired? Okay? Are you so depressed that you can't get out of bed in the morning and go to school and you fail out of your school classes? Your behavior, whatever you've got going on, is maladaptive. It might be a psychological problem. On the other hand, are you so anxious that you are just miserable all day long with fear and the feeling of dread in your heart? If you've got the feeling of dread in your heart every day, you are, and you are unhappy about it, or you are so sad and all you do is cry every day and it makes you feel bad, you're experiencing psychological distress. You might have a psychological disorder. Or if what you are doing is so outside the realm of what is expected and allowed in this society, if your behavior is deviant, we might say you have a psychological disorder, right? So the weird thing, the difference between diagnosing a psychological disorder and a medical disorder is a medical disorder is diagnosed using biological correlates that indicate that you truly have high blood sugar, that you have high cholesterol, that your heart rate is too high, that you have a cancerous tumor, that you have a broken bone. We can see all of these things with images and blood tests and get these physiological correlates that tell us whether or not you're sick. Not so much with psychological disorders. Instead, we have to look at it as a behavioral syndrome that makes you unhappy, unproductive, or is just so oddball that you can't fit in. That's the weird thing with psychological disorders. They are different. That's what makes them so much more different than medical disorders. Does that make sense? Do you understand how it might be more difficult to get diagnosed with a psychological disorder? Now, here's the weird thing. If you've ever seen one of those court cases where somebody's trying to argue not guilty by reason of insanity, there's always a huge outcry and people stake their positions one way or the other. Oh, that person's truly sick. Give them some help. Other people will say, no, they're just faking it. Send them to the electric chair. You know what? Both of these groups are arguing, and the reason there's so much controversy with these diagnoses in court cases is because there's really no biological correlate. I can't tell if you're depressed. I can't tell if you're anxious. I can't tell if you're schizophrenic unless you suggest to me that you are. Very, very difficult, okay? Now, here's the deal. This is difficult. It is almost impossible. But in order to make it just a little bit more systematic, to give us a little better chance of figuring out who has psychological disorders and what disorders that we have, psychology began borrowing from the medical field about 75 years ago in the late 40s. After World War II, we had all these psychiatric needs. Psychology realized that it needed to get more efficient and more accurate at diagnosing psychological disorders. And they began to move towards this medical model of psychological disorders. What does it mean to say the medical model? Basically, what we're going to do is we're going to treat the diagnosis of psychological disorders as similarly to the diagnosis of medical disorders as we possibly can. No, I don't have blood tests. No, I don't have x-ray machines. No, I don't have scanners or any of this stuff. So I don't have the technology that the medical doctor uses. I don't have the ability to see organically what's wrong with you, but I'm going to use the process and attempt to be as systematic and as scientific as possible in order to treat people with psychological disorders. Now, your book is going to suggest that this is a stark contrast into how mental illness used to be perceived, and typically in the field, if you take an abnormal psych class, they'll tell you about how in the 16 and 1700s, if you had psychological disorders, they said you were possessed by the devil. In Freudian era, in the late 18th or 19th, in the late 19th century, they thought you had some sort of psychosexual problem with your mom. Now, we treat psychological illness as a medical disorder. And hopefully, and if you talk to clinical psychologists, they will tell you that the use of this medical model has brought much needed improvement into patient care. Okay. Now, there is still a lot to be desired about the clinical diagnosis of psychological disorders because it's still infinitely a difficult process of trying to diagnose you based upon your stated behavior. But we are going to use some medical terms and some medical procedures that allow us to know more and to act more effectively with regard to the treatment of psychological disorders. The term diagnosis, just like clinical medical doctors, clinical psychologists use the idea of diagnosis. Etiology, just like your doctor can tell you what things you shouldn't do if you want to avoid cancer or high blood sugar, your doctor knows what the etiology, what causes these disorders. Clinical psychologists are interested in trying to understand the causality of psychological disorders. Why do people have schizophrenia? Why do people have anxiety disorders? What causes people to be depressed? Now, to be honest with you, unlike medical disorders, the answer to these etiology questions are still not sufficiently answered. Nobody really knows why you get depressed. Nobody really knows why you get schizophrenia. Nobody really knows, but we are interested in understanding the causes of these disorders because that, number one, allows us to tell people what they can do to avoid these psychological illnesses. And number two, it allows us, if you know what causes a disorder, then it makes it easier to treat the disorder. So if you look in the DSM, the Diagnostic Statistic Manual of Mental Illnesses, you'll see that each and every disorder has an etiology, a perceived cause. And then we talk about prognosis. Just like I know what's going to happen. If you get the common cold, this is what's going to happen over the next couple of days. You're going to cough, you're going to sneeze, you're going to feel terrible, you're going to have a headache, you might have a tummy ache, and then all of these things are going to go away over the next 3 to 4 days. That's the prognosis. If you went in and said, Doc, I have a cold, what's the prognosis? The doctor would say, this is what's going to happen in the next several days. If you have, let's say, cancer, and you go into the doctor and you say, doctor, what's going to happen? The doctors say, well, the cancer is going to do this, this, and this, and this. If we treat it, this will happen. If we don't treat it, this will happen. That's a prognosis. Just like in medical disorders, we try to come up with prognosis for psychological disorders. Did you know when people have schizophrenia, there are 3 basic paths that schizophrenics follow? Some people have one schizophrenic break, lasts a couple of weeks, they get better, never ever happens again. It's just that weird month that they had in their life. Some people will have a schizophrenic break, then get normal, and then after a while, they will have another schizophrenic break, and then they'll get back to a relatively normal state, and then they might have a schizophrenic break a year later, and then get back to normal. And so some people have schizophrenia occasionally. And then some people, we call them the chronic schizophrenics, they have that one schizophrenic break and they never come out of it. And so did you know there are 3 patterns with schizophrenia, the symptoms of schizophrenia? That represents prognosis. I can also tell you what's likely to happen if you take the medicine versus if you don't take the medicine. That's also prognosis information. And then clinical psychologists, just like medical doctors, want to know how often psychological disorders occur, right? And because if we can see the incidence of a behavior, the incidence rate of a behavior changing, that begins to tell us that we need to look in the environment and see whether or not something is causing the increase in this incidence rate. You know, there's this weird shaking disorder that is typically identified in 1 to 2% of teenage patients, and it develops over several months, this spasmodic sort of shaking disorder. Crazy thing, about 2 years ago, doctors started seeing this, and the incidence rate jumped up from 1% all the way to 20% of their intake patients in the space of a couple of years. And instead of happening slowly, it happened almost automatically to these, and it was mostly to females. And doctors began to tie the occurrence, the rise of this particular psychological disorder with the beginnings of TikTok. There are actually people who think that the introduction of TikTok into social media has caused this shaking behavior in young teenage girls to spike. And so incidence rates allow us, and prognosis allow us to know a little bit more about the disease. So in a sense, these are terms that clinical psychologists have found that it's very valuable to use in order to begin treating the psychological disorder process. All right. Now, the APA Association uses this thing called the Diagnostic Statistic Manual. It's in its fifth revision. That is, this is the fifth. It's been revised 5 times, and it is used to classify disorders. And basically, it provides detailed information about various mental illnesses that allows clinicians to make more consistent diagnosis. It is nothing but a book of lists. It is nothing but a book of lists. It lists all of the symptoms of every disorder. And so what happens when you go into your doctor, you tell them the presenting problem, doctor, I'm feeling really anxious and it's disrupting my work. The doctor will then begin to do their interview process. They talk to you, they may give you some personality tests, they may talk to your friends, and they collect all the symptoms that you seem to be experiencing. Then they go to the chapter on anxiety-related disorders because you told them you were feeling anxious and not sad, and they tried to fit your symptoms to the list of symptoms that for a particular disorder. And if they get a good fit, then they will give you that diagnosis. On the other hand, if you go into your doctor and you say, doctor, I'm seeing things and I'm hearing things, and your doctor says, this person might be psychotic. They then do the interview with you. They'll give you personality tests. They'll interview your friends and parents. They collect your symptoms. They then go to the chapter on psychotic disorders and compare your symptoms to each of the different types of psychotic disorders to discover which list of symptoms is most similar to the symptoms that you have. And so the DSM book is nothing more than a list of behavioral symptoms that your clinical psychologist uses to compare your symptoms to the symptoms that we know about for different psychological disorders. Does that make sense? Does that make sense? Now, keep in mind that this clinical psychologist is still diagnosing your disorder without any biological correlates. It's the same thing as the medical doctor telling you you have a broken leg without actually doing an x-ray. It's the same thing as your doctor telling you that you have diabetes without doing a blood test. Okay? Now, I'm not downing clinical psychology. I'm not saying that clinical psychologists are not professional, but the biological correlates don't exist for psychological disorders. And so we have to use this sort of secondary way, this indirect way of detailing whether or not someone has a psychological disorder. Now, this is the DSM-5. It's had a little bit of change. Don't worry about the multi-axial system. I'm not going to ask you about that. I don't know why your book includes that on the PowerPoint. But it's mainly categorical. All right, now, and the weird thing is, you may look similar to one or two diagnoses, but I have to put you into one of these categories. Are you suffering from generalized anxiety disorder, or do you have a phobia? I can't say that you're 20% phobic and 80% anxious. I can't do that. I have to put you into one or the other category, and I have to make that choice based upon these symptoms that you describe to me. All right? Does that make sense? Do y'all understand the difficulty in that clinical psychologists have to go through in order to diagnose psychological disorders? There's no simple test. There's absolutely no simple test. Now, what I'm going to do is this class test. Chapter anxiety disorders. And chapters going to have all too much impact you. We're going to talk about 4 of these. There are more of them than just we're going to talk about 4 of them. General disorders, having phobia, sound problems now. Hello, 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 hello. Sound problems. So are you hearing sound problems now? You are hearing sound problems. Can you hear me? Can you hear me? Is the sound better now? Can you hear me? Can you hear me? Okay, it's good now. I wonder what the hell happened there. That's bizarro. Is it good or you can just barely hear me? I'd be curious. Okay, good enough. We'll go with that then. All right. Generalized anxiety disorder is a chronic high-level anxiety not tied to any specific threat. Now, we're going to differentiate that and do a differential diagnosis, okay, because some people are just anxious, but they can't point out any one thing. They're just always nervous. They're just always uptight. They're just always stressed. This may be diagnosed as generalized anxiety disorder, a chronic high level of anxiety not tied to any specific threat. On the other hand, we're going to differentiate that from people who have a specific persistent irrational fear of an object, okay, that presents no realistic danger. Now, are you supposed to be incredibly afraid of a lion? If there was a lion or a tiger in your bedroom, hell yes, you ought to be scared. It would be completely normal to freak out and run away from that lion in your bedroom. However, if there is a beetle or a grasshopper in your bedroom and you freak out and run away, you may have a phobia of that particular animal. So we typically differentiate. Phobic disorders are these irrational fears that are out of proportion to the threat caused. That's the key. It's got to be out of proportion to the threat caused. If you have a phobia of a specific thing and it impairs your day-to-day functioning, then you may be given the diagnosis of a phobic disorder. Now, I will tell you, as a general rule, you don't see a lot of phobias specific phobias described in your DSM, because for the most part, phobias don't impact our day-to-day functioning. You may have coulrophobia, the fear of clowns, but why would I treat that if you don't work in a circus and you never see clowns and you can do all your day-to-day jobs and you're not depressed about clowns, and you just freak out every time you see one, then you know what? Maybe we're not going to treat your clown phobia. Allurophobia. Does anyone know what allurophobia is? That is the irrational fear of cats. Psychologists don't treat that because people who are afraid of cats just avoid them and go on and do their day-to-day activities. However, if you have claustrophobia, the fear of closed-in spaces, and you can't get in a car to go to work, that's a problem that's going to screw your life up. And so in that case, we'll treat your claustrophobia if it keeps you from going to work. Now, remember, I mentioned a couple slides over, it's all about the presenting problem. People who have allurophobia don't go to clinical psychologists because it's not a problem for them. People with coulrophobia don't go to clinical psychologists because there's not a problem. People with claustrophobia sometimes go to psychologists because they can't get in a car, or they can't be in a bedroom, or they have situations which cause them great distress and impair their functioning. Right? So, two different kinds of anxiety disorders is this generalized level of anxiety that just remains high and there's no particular target. Some people, on the other hand, have one particular target that super duper sets them off. And this target is so important enough that it stops their ability to function as a normal human being. All right? Now, we're going to differentiate those two types of anxiety from what we'll call panic disorder. Panic disorder, I don't know, has anyone in here ever had a panic attack before? A panic attack is just like this burst of arousal that comes out of nowhere, causes your heart to beat super duper fast, causes you to hyperventilate. Sometimes the world speeds up. people feel like the world is crushing down on them, and people feel like 1,000 pounds of weight is on top of them. And people will go through these short, recurrent attacks of overwhelming anxiety that occur suddenly and unexpectedly. They just automatically just this huge fear response, and they don't know what it is in their environment that necessarily causes that, but they have these panic attacks. Now, that's different than generalized anxiety disorder because these people don't have anxiety most of the time. They just have these brief periods of terror. Now, panic disorder is different from phobia disorder in that the phobic disorder, this fear is caused by a specific target or object. With the panic disorder, it just seems to come out of nowhere. So do you see how we have 3 different types of anxiety that cause people distress and impair their functioning? But each of these 3 is a different way of experiencing too much anxiety. Just a general level of too much anxiety all the time, that's generalized anxiety disorder. Terror related to one object that keeps you from doing your jobs, phobic disorder. Just having panic attacks, these recurrent attacks of overwhelming anxiety with no particular target, that's panic disorder. Now, you'll notice below panic disorder, I do have this one phobia called agoraphobia, the fear of going out into public places. I remember I had a student one time that told me about her difficulty going to a grocery store. She could not go to a grocery store alone. She would freak out and have to leave the grocery store. She had trouble sitting in traffic where other people, in stop traffic, other people would look around in their cars and she could see other people. And she was agoraphobic. And she had a fear of going out in public places. Now, why do I put this down here with agoraphobia? The weird thing is we have this concept called comorbidity. Comorbidity. Sometimes 2 disorders occur together. Okay, occur together. So, one of the weird things that you're going to find is that people with panic disorder often develop a fear of leaving their house because they don't want to have a panic attack in the middle of public. And so people will actually develop a comorbid condition. So panic disorder is different than agoraphobia, but sometimes agoraphobia will lead someone to experience a sense of some panic disorder will cause somebody to develop agoraphobia, right? Now, obsessive compulsive disorder. This is another anxiety-related disorder. So we have generalized anxiety disorder, we have phobic disorder, we have panic disorder. 3 different ways to demonstrate too much anxiety. Some people develop to demonstrate their overwhelming sense of anxiety by engaging in compulsive ritualistic behavior. So a person with obsessive compulsive disorder, they're going to have the anxiety that's with them all the time. They're going to have an obsessive thought. Typically, it's a fear of some sort. I'm afraid of dying. I'm afraid of catching a disease. I'm afraid of this. I'm afraid of this. And this obsessive thought, this fear of this thought, causes them to engage in compulsive behaviors which reduce temporarily the anxiety that causes the obsessive thoughts. So what you're going to see is a lot of people have a fear of contamination. That's a very common obsession. I'm afraid of getting dirty or infected. And so what people will do is they will engage in washing behavior that designed to make them feel better and to reduce the fear of contamination. Now, it's a good idea to wash your hands before you eat and after you eat and after you go to the restroom and before you go to the restroom, etc. Not a bad idea to wash your hands, but some people wash their hands 50, 60, 70 times a day. That isn't compulsive behavior. I know a person right now that thinks that they have a skin condition that causes their skin to lose flexibility, and they think that they're growing abnormal hairs in their body. And this friend of mine shaves their head for 3 or 4 hours a day. I've talked to this guy. I don't know what to do with him. It's a friend I've known for 20 years. And over the last year or so, he's developed this compulsive fear of this disorder that he thinks he has. And he shaves his head every day because he thinks that is helping his behavior. And he doesn't just shave his head once or for 10 minutes. He will literally, and he tells me about this, he'll send me videos of him shaving his head. And he'll shave his head for 2 or 3 hours a day. And then because he's shaving his head running a razor, his head gets chafed and red. And he said, look, see, the disorder is getting worse. And I keep trying to say to him, no, it's because you're shaving your head. You're dragging a razor across your bare skin for 2 hours a day. And so this person has an obsessive fear, this fear of getting sick, which causes them to engage in this compulsive behavior for hours and hours and hours. Okay? Now, common obsessions include fear of contamination, harming others, suicide, or sexual acts. And then people engage in these compulsive behaviors that temporarily reduce the anxiety brought on by the obsession. You know, you may think that your hands are dirty and be afraid of dying. You wash your hands, boom, fear gone. With a person who has OCD, their fear only goes away for a few minutes and then it comes right back and they have to engage in this compulsive behavior. And as your book suggests, true OCD disorders occur in about 2 to 3% of the population. Now, tons of people will say, oh, I have an obsessive compulsive personality. They'll laugh and tell you that they are obsessive compulsive about something. No, they're not. If you've seen a person with OCD, you'll know the difference between somebody who truly has OCD and somebody who is just doing something that they think is funny or that they've repeated before. And that's different. Now, obsessive compulsive behavior is different from an obsessive compulsive personality. We're going to talk about personality disorders probably tomorrow. But an obsessive compulsive disorder is typically composed of one fear and one behavior that reduces that fear. However, some people have a personality style where their general personality is anxious, and what they do is they are compulsive about everything in their life. They're compulsive about being on time, they're compulsive about their grades, they're compulsive about how they eat. They have all of these weird rituals that just seem to pervade their life. This person would get the diagnosis of compulsive personality, as opposed to impulsive compulsive disorder. OCD and OC personality are two different things. Now, Now, what are the etiology? What causes anxiety disorders? I will tell you that there is genetic research suggests that there is a genetic component to anxiety disorders. My mom was anxious, so I'm a little bit anxious. My mom scored neurotic. I scored neurotic. So it's quite legitimate to say that there is a genetic component to anxiety disorders. And one of the things that we do know is that if you give people drugs that magnify the level of GABA, which is a neurotransmitter in their brain, their anxiety symptoms go away. Now, this is not the same as knowing exactly how GABA is related to anxiety, but we do know that if you give a person a drug that magnifies the neurotransmitter GABA in their brain, their anxiety goes away. All right? And so there are sort of two basic beliefs with biological factors. We know that there's a genetic component, some way in which the brain is built. And we know that if you give somebody a drug that magnifies the GABA in their brain, their anxiety goes away. So we think that neurotransmitters and some sort of biological factors play a role in anxiety disorders. Hopefully, you're out there saying, wow, Chris, could you be any more vague? You haven't really told us anything about how specifically your biology of your brain creates anxiety. You know what? Nobody does. The state of knowledge does not, the state of professional knowledge does not know how any psychological disorder is really caused, especially by biological factors. All right. Now, what else causes anxiety disorders? Well, if you remember, I think we talked about little Albert and the kid who was conditioned to have a fear. Did you know that you can learn a phobic response early in your life? So you can actually be conditioned to develop a phobic fear. Look at this picture right underneath me. Okay, so we have a little kid. Let's say, here's a crazy thing. I had a bad experience with snow when I was a 2-year-old. I was out in my little snow clothes. We were up in Maryland, and it had snowed like a foot or two. And I was out walking, and I tripped and fell in the snow, and I was buried in the snow. And I swear to God, this is true. I freaked out as a little kid, and it was a very scary event for me. Now, that didn't cause any sort of changes in me. That didn't change my life. However, what it did was it scared me one time. Let's say that happened, and I developed this classically conditioned fear of the snow. I had one bad experience with the snow, and it caused me to be afraid. Now, the next time the snow came and my parents wanted to go outside, I said, no, I don't want to go outside. And I started crying. My parents said, well, you know what, Chris, you don't have to go outside. And they let me stay inside. And so staying inside reinforced my fear of the snow. My parents let me avoid the snow. They even gave me some cookies to eat. And my behavior of avoiding the snow was reinforced. So we know that people may learn phobias and may learn to be anxious as well. Now, most people don't develop a snow phobia, but they do develop a dog phobia. Most people don't develop a sunlight phobia, but people can easily develop a phobia of snakes, right? And this guy, Robert Seligman, argued that human beings are biologically prepared to fear some things. Water can be dangerous. It's very easy to develop a fear of swimming, right? Spiders and snakes can kill you. They have poison. So it's easy to develop a fear of spiders and snakes. Kool-Aid, not going to kill you. Hard to develop a fear of Kool-Aid. Peanut butter sandwiches, really hard to develop a phobia of peanut butter sandwiches. Seligman, this guy Robert Seligman, argues that there are some things in our environment that we can easily be trained to fear, and this provides adaptive value. So what you're going to find if you're a clinical psychologist is that your people are typically going to come in with certain types of phobias, and you're not going to see other phobias like pencil phobias, paper phobias, but you will see sex phobias, you will see arachnophobias, you will see claustrophobia or agoraphobia. You'll see things like this. Now, and then the final, let's see, are we going to talk about that? No. Okay. And then some people are more likely to experience anxiety disorders because they develop an explanatory style. Some people, when they're brought up in life, their parents teach them how to interpret all kinds of events as threatening. If you remember, we talked about stress and stress reduction. I suggested to you that becoming stressed is a learned habit. It depends on the way you interpret things. And people have habits of how they interpret things. And so some people learn to interpret things and get uptight, and they experience stress more often than other people do. Other people understand that good and bad things happen, and so when bad things happen, they aren't stressed out about it. Well, some people, their parents train them to interpret the world in a hostile manner. And these people learn to focus their attention on threats and not pay attention to things that aren't related to threat. And so some people actually learn the habit of interpreting the world in a fearful manner. So, lots of different kinds of anxiety disorders: generalized anxiety disorder, phobic disorder, panic disorder. You can have a specific phobia called agoraphobia. You can be an excessive compulsive person. Where does this come from? Well, it can come genetically, yes. We know it has something to do with the neurotransmitter GABA in your brain. But we also know that people can learn early in their environment to be a person who interprets things in a fearful, habit-forming way. Okay? Now, your book talks about dissociative disorders, not the most common of psychological disorders, but let's talk about it. A dissociative disorder is a class of disorder in which people lose contact with portions of their identity, If you remember, I talked about this the other day. I suggested to you that each and every one of you has a self-schema, right? Remember Chris. He's an athlete. He's a professor. He has a good humor. Remember, he's short. This is my self-identity right here. This is my self-identity. What happens sometimes in dissociative disorder is a person will have a break, and they'll have identity 1 and identity 2. So in a sense, a person will fracture their identity, okay? And this is known as a dissociative disorder. Almost always, this is a result of extreme stress. Extreme stress causes people to develop dissociative disorders. Now, there are two basic dissociative disorders I want to talk about, okay? Now, in dissociative disorder, in dissociative amnesia, you'll notice dissociative amnesia, what will happen is, I'm not going to go to that. A person, a lot of times, will actually lose their sense of self. They will forget who they are. Now, that's different from regular amnesia. Sometimes people get a bump on their head and they'll forget what happened to them last week. They may forget what happened a month ago. They may not remember anything that happened the last week or 6 weeks even, but they still know who they are. Dissociative amnesics actually lose a sense of who they are. So when you ask me to look at this as a dissociative amnesic, I wouldn't know any of this. I wouldn't know any of this at all. And here's the crazy thing. Occasionally, people who have dissociative amnesia also experience fugue, F-U-G-E. Dissociative amnesia with fugue, F-U-G-U-E. And basically what happens when somebody experiences the fugue, they will actually travel. So imagine losing your sense of identity, Dimitro. You don't know who you are anymore, but you got $50 in your pocket. So you go down to the bus station and you buy a bus ticket to the next town or to the next state. And 3 months later, Dimitro, your wife finds out that you are now working at a Waffle House in South Carolina and your name is Ted. All right. And you've completely forgotten who you were. You experienced dissociative amnesia, and it caused you to go into a state of fugue. You traveled, you took off. And so one way in which people lose themselves, sense of self, and dissociate is they forget who they are. They forget their sense of self. Now we're going to differentiate that from the person who actually becomes multiple selves. And this is known as dissociative identity disorder. You folks have probably heard of multiple personality disorder. Multiple personality disorder. This is multiple personality disorder. This guy's name is Alex. He's a professor and he's a badass, right? That's my identity 1, Alex. On the other hand, my identity of Fred is short, humor, and he is weak. And so now I have two senses. Sometimes I'm Alex, sometimes I'm Fred. The crazy thing is, people, a lot of times, these selves don't even know that each other person exists. And you can't control when you go into these persons. But some people will develop more than one identity, two identities, three identities, four identities. Now, each personality will has its own name, its own memories, its own traits, its own physical mannerisms, and some people have even suggested its own pattern of brain activity. And people can transition between these identities super duper suddenly, and the differences between them can be extremely strong. So you can have a male side and a female identity. You can have a black identity and a white identity. You can have an angry identity and a super weak identity. And you can bounce back and forth between these identities quickly on a moment's notice. Now, here's the deal. Dissociative amnesia and dissociative identity, there are really no genetic or biological markers for these disorders. We typically think that these disorders are the product of extreme stress that some people feel. Okay, the causes of these are largely unknown. We think they're related to stress because typically the people who demonstrate these disorders had a precipitating event which was high in stress, or at least from the outside, it looks like a high stress. Many clinicians suspect that DID may result from severe emotional trauma that occurs early in childhood. Now, the crazy thing is, here's the weird thing about psychological disorders. Some psychological disorders are culture bound. That is, you'll see some psychological disorders in this culture, but not in other cultures. Until recently, dissociative identity disorder was only seen in Western cultures and almost exclusively seen in American cultures. So it was almost as if dissociative identity disorder was this sort of American European psychological disorder that only happened to American patients, usually high functioning people. And so a lot of people said dissociative identity disorder is made up if it only occurs in one culture. And the weird thing is, there was a very famous movie called Sybil that came out in the early 70s. And after that, Sybil was the movie of a person with dissociative identity disorder. And bizarrely enough, tons of dissociative identity disorders started occurring after that movie. And there was this spike that has lasted since then in the incidence of dissociative identity disorders, relatively unheard before the movie of Sybil in the early 70s. Afterwards, the incidence rates of dissociative identity disorder peaked and has stayed high, right? So, dissociative disorders. So some people's disorders are related to a lot of anxiety that they can't manage that impairs their functioning. Other people, on the other hand, their identity seems to fracture. Now, it may be related to anxiety. It may be caused by anxiety or sad events, but the disorder itself isn't characterized by anxiety. It's characterized by a fracturing of the ego, if you will. Dissociative identity disorder. Crap. You know what? We have ran out of time. I'm going to ask you to read about mood disorders on your own. Ask you to read about mood disorders on your own. I want you to learn the characteristics of a depression versus bipolar disorder. Bipolar disorder is when you have periods of mania and periods of depression, whereas a person with depression only has the depressive symptoms. So, and if we have time on tomorrow, I might come back and revisit that just a little bit. But I want you to go ahead and learn about depressive disorders on your own. All right, so that's all I have to say for chapter 14 so far today. I'm going to come back and finish that up and talk about a few more disorders tomorrow. Any questions? Don't forget, this week your job is to finish the course evaluation and to email me a confirmation that you get when you complete this course evaluation. It won't tell me how you scored me. It will just tell me that you completed the course evaluation. You can either email that to me or you can upload it to the discussion link for this week's discussion board, and I'll grade it that way. Does anybody have any questions? Dimitro, thanks for coming. Johanna, thanks for coming. Matt, thanks for coming today. I really appreciate you, and you have a great day too. Folks, take care, and if you need anything, don't hesitate to contact me. Otherwise, take care and have a great day. Bye.